I'm like, okay,
That's how I am. I get too tired by the end of the day. I'm like, I can't even.
it's like you focus so much on trying to focus that you can't focus.
Yeah.
My clicker go.
Don't you have that happen where you're focusing on trying to focus so much and not focus on anything else?
I come out of here, my vision's all blurry.
I know.
All right, so the lab session for the oral surgery procedures. Go over this pretty quick, and then we'll this is the lab that we'll be doing today.
Are we doing lecture 22?
22 for emergencies.
No, 20 for lecture 20. Oh, yes,
Emergencies.
yes.
Yeah. I'll start. I'll do the first page and a half or so, and then we watch a movie.
Oh. I'll just keep it open.
So the oral surgery procedures is basically a routine tooth extraction, alveoloplasty, which is a reshaping of the bone, a surgical tooth extraction, meaning that you have to reflect the gum tissue or section a tooth. Those are considered surgical extractions. If you just wiggle the tooth out, that's a routine extraction. Removal of impacted third molars, those we normally send out to the oral surgeons. Biopsies, again, to test the tissue that's abnormal. And then a dental implant surgeries that are done to place the implants themselves. Procedure for a surgical and dental extraction. The introduction, we remove a permanent or primary tooth that has erupted into the oral cavity. What we need, again, basic stuff that you normally have, mouth mirror. This is the difference. You need a surgical high volume evacuator, or a surgical tip, we call it, plus your regular tip. You need a tongue or a cheek retractor, something that's going to pull away the tissues. Anesthetic, obviously. Periosteal elevator, again to reflect the gum. And a high-speed surgical handpiece, which here, there is such a thing as a surgical handpiece that the oral surgeons have, which has a different angle. Instead of being the bird being straight down, it's at about a 45-degree angle, which gives them a little better angle for removing bone or sectioning teeth. But here we just use our regular handpiece. There it is. You need some sort of elevators, the root tip elevators. Again, just if the root tip breaks, your straight elevators, we'll go over that. Any forceps that you need, hemostats or needle holder, the curette, which is the big spoon, and the suture. What's done? The dental assistant, again, you're going to take the blood pressure, make sure the patient has signed consent. Tell them we're going to take out such and such a tooth. These are the possibilities. And then normally when the doctor comes in, he checks the consent form and asks if there's any questions and maybe highlights anything. The dental assistant, and we'll go over some of the risks when we do the lab. Dental assistant mounts the patient's x-rays, delivers the dentist the mouth mirror, and so that he can take a look. Topical anesthesia, if you haven't placed it. The dentist checks to make sure they're numb. Okay, the first thing that we use to start the extraction is the periosteal elevator. Okay, again we check to make sure he's numb, and then we go around the tooth that we're going to extract, and we kind of cut away that gum tissue around the surface of the tooth. Then, so periosteal elevator. Then straight elevators are the next ones, again right here. And basically the straight elevators, what we start doing is we start putting pressure on that tooth to start to get some movement, some bone expansion. Because the tooth, that's how we make the tooth come out. You put pressure one way and you push and compress the bone. Then you put pressure the other way and you push and compress the bone. And you're just slowly creating a little bit of space as you kind of mash that bone together. And you get it rocking back and forth, and finally you get enough force to pull out a tooth. Okay, so that's kind of how teeth come out. So you use a periosteal for the gum, then your straight elevators, and you start doing the luxating of the tooth. So there's different types of elevators, and you normally start with a small, medium, and a large. So the first elevator you'll be small, then he'll ask you for another one, which is the medium, and then the third one is the large. They just vary in the width of it. Your responsibility when we're doing this is, again, sometimes these teeth have large fillings, sometimes these teeth have crowns, sometimes these teeth will break. Okay, as an assistant, you have to be ready there, okay, with the suction, okay, because your main job there really, you're going to be suctioning on the blood so we can see. But should anything fall, a piece of filling, again, remember the patient is laying back, a piece of filling, the tooth break, or crown break off or something, you've got to be there with the suction, ready to suction that out. Normally we'll put what's called a throat pack, which is just a drape behind it, but even so, you have to be ready to catch anything that falls off. Again, if the tooth breaks during the removal, leaving the root, so you'll need a high-speed surgical handpiece to use to relieve the alveolar bone, and root tip elevators. I think that's on the test. So you need a high-speed and root tip elevators should you need to go in and retrieve any roots. Once you remove enough bone and you can access the roots there, then you start using your elevators, and again you start putting pressure on one side and the other just to loosen those up until you can get those out. This, when
If we don't have that bottom there, we need 6 centimeters.
Being 6. But it doesn't say that on no, on 7 it doesn't say at the bottom there where it's underlined where
It
it's
stops at
Yeah.
rooting roots.
So, yeah, if we're using a surgical handpiece, basically, or our handpiece, again, we're squirting water in there, okay? So, and you're cutting away. So you can't use your surgical tip, which is the small tip, when we're using a surgical handpiece, okay? So you need to use your high volume, your regular one with the big opening to suction. Okay, so sometimes, especially here, there's only one room now that has 2 high volume evacuators. That's in one of my rooms. All the others only have 1. So if you're doing surgery in one of those rooms that only has 1 high-speed volume evacuator tip, then if the doctor switches to do a surgical extraction using a high speed, then you've got to switch from your surgical suction tip, switch that out to your regular high volume tip, okay? Because the other one, with all the water, you won't be able to keep up and drown the patient, okay? So you've got to be able to switch just when you're using the high speed or the surgical tip or the high speed with water. Okay, anytime when we're just elevating, if we're just using our elevator, you're using the small tip, the surgical tip, basically to suck away on the blood so we can see where we're putting the pressure. Okay. Okay, so after the tooth comes out, we'll check, make sure everything's come out, use a curette, make sure there's nothing sharp there if we have to remove with the rongeurs. Then we're going to instruct the patient to bite down on a gauze. And again, just like any cut, you bite down on the gauze for 5 to 10 minutes, make sure the bleeding stops. And normally we'll hold them here at least for the first gauze change, which is about 5 to 10 minutes after the extraction. We'll change it just to make sure it's not oozing blood still. It'll still be bleeding a little bit, but you want to make sure that it's going to stop. Sometimes you take out that first gauze and then blood's just continuing to come out. At that point, we need to decide whether we put gel foam, which is like a clotting foam that helps the patient stop bleeding, and we may suture it to get it to stop bleeding. But we can't let the patient get out of the chair, if, you know, they're still bleeding, they're gonna get in the car and change their gauze and, you know, just keep bleeding. So that's the main thing, we make sure that they stop hemorrhaging before we let them out. Any instructions that we're gonna tell the patient after they leave? What are some of the instructions you think that we should tell them?
Don't smoke, don't suck on straws, don't switch vigorously. Don't smoke.
She knows.
That's it. No smoke, spit, suck on a straw.
Like, wow.
That's exactly right.
I got a lot of this last time, don't smoke.
That's how you tell them, don't smoke. So no smoke, spit, or suck on a straw.
And no, it's not okay to stick it to the other side of your mouth, okay? No smoking.
A lot of pain, bleeding that doesn't stop, or a lot of swelling, we normally need to see them back. You'll get a little bit of bleeding, a little bit of swelling, maybe some discoloration, but a lot is not. Okay, dry socket, we talked a little bit about this. Usually occurs after the 3rd to the 5th day, and that should have a little star. This condition is very painful and usually occurs between the 3rd and 5th day post-surgery. Okay, so that's usually when you'll get the patient to come in. Within a week, they'll come in and they'll be hurting. And you'll get a foul smell sometimes from the extraction site. If they do have a dry socket, this is what we do. Kind of clean out the area. Sometimes we need to numb them up. If not, sometimes they can put up because they don't want to be numbed up again. They can put up with. We rinse it out with Paradex, which is that bottle that we have of rinse in the operatory. Rinse it out with Paradex or a sterile saline solution, and we put gel foam or some dry socket paste. We'll show you what that is. Usually they get relief pretty quickly after you place that. Let's see, the test here. So again, if they come in with a dry socket, we'll numb them up if we need to, remove the suture, rinse it out really good. We put the paste. Make sure that we want to make sure that it bleeds a little bit again, because that's why it's hurting. And prescribe them pain medication and antibiotics if they need. All these are out here on the hall right now. You can take a look at it, and I think you may have the picture of these in your handout. Gel foam is a clotting foam. You got the rongeurs, sutures, hemostats or needle holders. Your scalpel blade, the holder, the elevator, straight elevators. You've got criers, or these are called flag elevators as well. Root tip picks and your different types of forceps. And Dr. Cervantes can go over those right now when we're done.
Now we're done with all the lab notes.
I think these are the last lectures.
I know.
Pretty crazy.
Wow, but I'm thinking of labs.
All right, for this, the medical emergencies, I'll just go over the first couple of pages there, and then we will see a video.
Yeah.
So medical emergencies in the dental office.
Yeah, that's really nice.
Awesome.
Yeah,